Good afternoon. My name is Eileen Brady. Today I'm presenting my Master's Dissertation Defence from the School of Nursing and Midwifery, Robert Gordon University, Scotland, United Kingdom. So the aim of this presentation is to propose the application of Kolb's experiential learning theory to inform the educational role of nephrology nurses in a pre-dialysis clinic in Saudi Arabia. And the objectives of this presentation are to: 1. Assess and analyse the learning needs and learning styles of the nursing staff. Understand the application of Kolb's experiential learning theory to inform the educational role of nephrology nurses in a pre-dialysis clinic. Enable the nephrology nurses to assist pre-end stage kidney disease patients to have a planned start onto renal replacement therapy. So the outline of this presentation will start with an introduction, background and statement of the problem, stages of chronic kidney disease, the literature review, theoretical framework, the methodology, results, findings, recommendations, and the conclusion. So the introduction. The rising incidence of end-stage kidney disease worldwide is attributed to changing lifestyles, high population growth, and rapid urbanization. Incidence of end-stage kidney disease is rising not only globally but also in Saudi Arabia. Two factors that affect the status of chronic kidney disease in Saudi Arabia include high rates of diabetic nephropathy and shifting of age demographics. Statistics show that the prevalence of renal replacement therapy has increased from 361 per million population in 1995 to 874 per million population in 2008. Furthermore, the prevalence of dialysis patients increased from 187 to 463 per million population. Renal transplants increased from 168 to 371 per million population. The annual prevalence rate of end-stage kidney disease is 753 per million population, with 10,203 patients on hemodialysis, and this number is expected to exceed 15,000 by the year 2015. So, statement of the problem. Although a pre-dialysis program is currently being piloted to accommodate the management of the increasing number of patients with chronic kidney disease, operational needs are not structured to meet the learning requirements of both nephrology nurses and patients. The care needs of chronic kidney disease patients with stage 4 to stage 5 is poorly managed, which is evident by staff and patient complaints regarding lack of pre-dialysis education. Medical records indicate that pre-end stage kidney disease patients are referred late to the nephrology service and commence treatment as crash starters without a smooth transition onto renal replacement therapy. So resources are not being utilised effectively because crash starters enter therapy as expensive acute patients, which leads to increased hospitalizations. Evidence suggests that lack of chronic kidney disease knowledge and education at stages 4 and 5 is associated with increased morbidity or mortality, limited choice of treatment modality, costly hospitalizations, and reduced quality of life. So we have the different stages of chronic kidney disease, and the National Kidney Foundation Kidney Dialysis Outcome Quality Initiative guidelines stipulate the use of the term to include 5 stages. The different phases are determined by the glomerular filtration rate, which is considered the best overall index of renal function, ranging from stage 1, which is a normal rate of kidney function, to stage 5, in which near total loss of renal function occurs. Stage 5 of the disease trajectory is known as end-stage kidney disease, which requires some form of renal replacement therapy to achieve near normal lifespan, extend or improve the quality of life of patients. The non-curative supportive treatment modalities available are hemodialysis, peritoneal dialysis, transplantation, and/or no treatment. Patients with chronic kidney disease who are expected to progress to end-stage kidney disease are classified as pre-dialysis. So the literature review. The studies are organised into themes such as the role of nurses in staff education programmes, experiential learning and vital elements of a staff education programme. Role of nurses. In this review, I mainly focused on three aspects of nurses' roles in staff education programmes, namely the educator, the mentor role and leadership role. Boehner 1984 described the 7 domains of nursing practice, namely the helping role, the teaching coaching function, the diagnostic and patient monitoring function, effective management of rapidly changing situations, administrating and monitoring therapeutic interventions and regimens, monitoring and ensuring the quality of healthcare practices, and organisational and work role competencies. So nurses begin the profession as students and fail to see the progression from novice to expert. Boehner pointed out the relevance of skills cumulatively acquired through time to indicate the progress of the nurse in the healthcare profession. Hilton and Pollard 2005, they explored the role of clinical demonstrators to assist the improvement of teaching and learning effectiveness in clinical skills. The findings of the study revealed the innovative role of clinical demonstrators and how they produced a positive effect on teaching and learning core clinical skills for students at all levels. This study is relevant because it provides a pathway for educators to evaluate education programs using action research. According to Billings et al., nursing competence is related to the acquisition of relevant knowledge, development of psychomotor skills, and the appropriate application of knowledge and skills within a given situation. This innovation appears to have produced significant outcomes in nursing education, as researchers have established that nursing students regard the simulator experience as beneficial. Klinkhammer 2012 postulate that nurses have dual roles of educators to prepare the nursing staff through in-service and practice-led programs to develop, maintain and improve clinical skills, as well as educate patients regarding care and health maintenance. Bonner 2003 explored the concept of recognition of expertise in nephrology nursing and emphasized the role of expert nurses as mentors in facilitating the skills development of novice nurses in clinical practice. She also identified how non-expert nephrology nurses seek guidance and assistance of expert nurses with their practice. Expert nurses are perceived to know more about nephrology than non-expert nurses and are recognized as role models. Bonner and Greenwood 2006 conducted a grounded theory study on the acquisition and exercise of nephrology nursing expertise and revealed a 3-stage skills process that was identified as non-expert, experienced non-expert and expert stages. This study is relevant because it was the first study conducted to explore nephrology nursing expertise and uncovered new aspects of expertise not documented in the literature. In particular, personal attributes are required to transit from one stage to the next and are important characteristics needed for the mentoring role. According to the Registered Nurses Association of Ontario, effective leadership is important for all nurses practicing in various fields as educators, mentors, administrators and practitioners. The RNAO linked the quality of professional leadership to good patient relationship and staff retention and recruitment. The American Nurses Nephrology Association identified leadership as a professional standard for nephrology nurses, where roles include being a team member and having the ability to work towards a vision or goal. Shira 2007 posits that nephrology nurses are also expected to influence decision-making bodies to enhance the delivery of quality healthcare and provide direction to improve the healthcare team. Finally, Adelman, Mullally et al. 2013 described leadership in the context of clinical nursing education. They also identified particular nursing practice skills that clinicians bring to nursing education to enhance leadership, knowledge, skills and abilities which are vital to nursing education. So in summary, nurses as educators, mentors and leaders have crucial roles in developing clinical skills and knowledge to promote patient-centered practice and improve the quality of service. Experiential learning. This provides the link between critical thinking and staff involvement. Boehner 2000 highlighted the novice to expert development of nurses and linked experiential learning to the philosophy of Taylor, and asserted that experiential learning is not based on aspects that could be quantified, but more on the aspects of developing qualitative distinctions and related these to past experiences. St. Onga et al. 2013 developed and implemented HIPPOC training to incorporate quality and safety education for nurses competencies in the curricula for pre-licensure nursing programs. The Kolb model served as a framework for the development of the HIPPOC guides because the theory appears to be suitable for nurses, for students of a particular discipline in which facts and concepts are understood, interpreted and assimilated for clinical decision making. Shewup 2005 applied Kolb's experiential learning theory as a framework to develop a 6-week perioperative nursing program for registered nurses with no previous experience in surgical services at Miriam Hospital. Although Shewup developed a program for new registered nurses, he demonstrated that the use of the model as a framework could be an innovative tool to develop professional courses to improve the quality of care. His work confirmed the viability of using the Kolb theory to develop a program to inform clinical practice. Vital elements of staff education programs. One of the responsibilities of a nurse educator is to determine the learning needs to define the level of knowledge of staff in relation to the desired outcomes of the program, the areas that need improvement and the knowledge gaps. Another important element is to determine the learning styles of learners to enable the nurse educator to develop appropriate learning materials and instructional strategies. Numerous studies on learning styles focused on professional nurses but not on undergraduate and graduate nursing school students. So learning needs assessment. Kanaski and Greenwich 2008 highlighted the need to address the individual knowledge base of oncology nurses besides addressing perceived needs and learning needs assessments. They concluded that it is inadequate to solely focus on specific learning needs that are included in the objectives of the education programme. It is also important to determine the knowledge base of each individual nurse. Koren et al. 2008 included an additional dimension in learning needs assessment. The authors considered the attitudes of nurses towards geriatric patients in planning for a gerontology curriculum. This study is relevant to the current research because it indicates the need for educators who design curriculum to consider assessing the attitudes as well as knowledge of students regarding older adults, the level of comfort and confidence in caring for geriatric patients. Murray et al. 2004 designed and implemented a learning needs assessment of nurses at a residential hospice using a cross-sectional multiple method approach. This study is significant to the current research because it provides guidance on how to develop appropriate, responsive and learner-validated education programs. While Ullman and Forbes 2007 developed a methodology to establish a valid learning needs assessment scale, they designed a psychometric approach with 3 phases of development and testing the assessment scale. Overall, the study suggested the development of learning needs assessment scale that is appropriate to particular specialist disciplines in nursing education. So learning styles, the 3 studies, Zauji, Hauer and Smith, use various versions of Kolb's learning style inventory to evaluate the learning preference of nursing students and professional nurses. Zauji et al. Found that most respondents preferred the converger learning style, whereas diverger and accommodator learning styles were the least preferred. Meanwhile, Hauer et al. 2005 compared the learning style preference of students from 5 allied health courses such as nursing, physician assistant, occupational therapy, physical therapy and speech language psychology using Kolb's learning style inventory 2A. The results revealed that the learning style preference of nursing and speech language psychology students is between accommodator and converger, and concrete experience was common between the 2 styles. By contrast, Smith found that most professional nurses who participated in the study were accommodators, 31%, followed by assimilators, 20%, divergers were 20%, and convergers, 19%. Cranell and White, 2012, determined the relationship between perceptual modality learning style preference and the preferred area of clinical practice among registered nurses in an acute care hospital in the US using demographic questionnaire and the perceptual modality preference survey. Cranell and White found that practicing registered nurses have varying learning style preferences across the 4 areas of practice, but no relationship was found between preferred area of clinical practice and learning style preference. Knowing the learning styles of the staff is fundamental in the design of appropriate learning programs. The results also indicated the preferred learning styles had no relationship with gender, age and years since undergraduate education. By contrast, Robinson et al. 2012 found a difference in learning preference between younger and older generations. Younger generations prefer assimilative or converger learning style, whereas older generations were more comfortable with concrete-based learning style because of their professional experience. Educators acknowledge that different learning styles exist among adult learners. Learners can be a heterogeneous mix of cultures, attitudes, backgrounds, and beliefs. According to Yang, adult learning is a relatively permanent change in behavior, cognition, or effect that occur as a result of one's interaction with the environment. Several models dominate the learning adult paradigm. The first adopts the Western rational tradition in which accurate representations of the real world is transmitted via scientific experiments. The second is the interpretive paradigm in which the learning experience is constructed out of personal experience to form the framework of learning. The third is the critical theory in which learning is viewed as the transformation process. Kolb described experiential learning as a process in which knowledge is acquired through the transformation of experience. According to Kolb, experiential learning has 4 elements that are expressed as a 4-stage cycle of learning: concrete experience, reflective observation, abstract conceptualization, and active experimentation. Kolb postulated that this process represents a series of learning modes in which the learner touches all the bases, a cycle of experiencing, reflecting, thinking, and acting. Therefore, experiential learning can only occur when a person is involved in an activity, reviews the activity critically, determines the things that are important, and uses this information to perform another activity. We will interpret learning styles by going through Kolb's learning cycle in more detail in the next slide. Carper's way of knowing include empirical, aesthetic, personal, and ethical, and the nephrology results are analysed against her 4 ways of knowing. Kolb's learning style. Kolb found 2 dimensions to the learning process, namely grasping and transforming experience. The model above describes the 4 phases of the learning cycle. There are 2 ways you take in experience: by concrete experience or abstract conceptualization. And there are 2 ways you deal with that experience: by reflective observation or active experimentation. When you use both the concrete and abstract modes to take in the experience, and when you both reflect and act on that experience, you expand your potential to engage in the learning process. He also proposed 4 learning styles, namely converging, assimilating, diverging, and accommodating. The converger is strong in abstract conceptualization and active experimentation, as well as strong in the application of ideas, and focuses on hypo-deductive reasoning to solve a particular problem. The assimilator grasps ideas by thinking and watching, and transforms experience by watching and reflection in formal learning situations. People with this style prefer readings, lectures, and analytical models. The diverger combines concrete experience with reflective observation and tends to gather information and uses imagination to solve problems. The accommodator combines concrete experience with active experimentation and reflects a hands-on learning style. This type of learner relies on intuition rather than logic. So the methodology approach used in this study was action research and transformation of thinking. The method involves a cyclical process of planning, action and evaluation, and has evolved in nursing because of the constraints surrounding empirically derived knowledge. So given that the study is limited to a proposed education program, two elements of the action research process, implementation and investigation of the change, are omitted for future application. Two tools were used to collect data for this study: a pre-post-test questionnaire with an education program as an intervention, and a learning style inventory questionnaire adapted from Kolb's learning style inventory test. The knowledge questionnaire was developed by the researcher to inform the educational role of nephrology nurses in a pre-dialysis clinic in Saudi Arabia. No known questionnaire is available to measure general nephrology nursing knowledge because of the complex nature of defining and measuring knowledge. The learning style inventory is a self-descriptive test based on Kolb's experiential learning theory that is designed to gain a better understanding of oneself as a learner and evaluates the way one prefers to learn or process information. Only 5 out of 20 questions were adapted from the original Kolb learning style inventory because of copyright restrictions. An advantage of this tool is that the researcher can consider different learning style alternatives and develop strategies to enhance the participants' learning potential. A non-probability convenience sampling of nephrology nurses at SAMHSA was utilised. So the results, we have the demography and emotional intelligence, we have the knowledge of participants in nephrology, and the results of the learning style inventory. So the demographic information. First of all, the majority of participants had a formal certificate in hemodialysis. That was 63.2%. The graph here shows the years of experience of the participants. The majority of the participants had greater than 10 years of experience in hemodialysis, which is indicated by 84.2%. Only a small percentage of participants had less than 5 years of experience in hemodialysis, which is indicated by 10.5%, and only one participant had 5 to 9 years of experience in hemodialysis, which is indicated by 5.3%. Emotional intelligence results. The graph shows the emotional intelligence results on important decisions. The majority of the respondents, 89.5%, preferred to guess randomly, whereas 5.3% followed their instincts and 5.2% relied on direction from others. Emotional intelligence is the ability to manage feelings and relationships, and self-awareness is an important component of emotional intelligence, which is subjective. The responses of the participants reflected the dominance of aesthetic knowing interrelated with the personal pattern of knowing. According to Reynolds, if more attention was given to critical reflectivity in the learning cycle than on guided reflection of the concrete experience, then the participants in this study could understand their own emotions at a deeper level. Emotional intelligence results continued. The graph illustrates the results of the rest of the emotional intelligence questions. Regarding the question on avoiding confrontation, only 5.3% of the participants strongly agreed that they avoided confrontation, whereas 47.4% of the participants agreed, 36.8% disagreed, and 10.5% strongly disagreed. For confidence about skills, talent, and abilities, 79% of the participants were strongly confident, 15.8% were confident, and only 5.2% disagreed. Regarding the question on feeling uncomfortable in emotionally charged situations, 15.8% of the participants strongly agreed, 36.8% agreed, whereas 26.3% disagreed, and 21.1% strongly disagreed. The responses of the participants reflected the personal pattern of knowing. The work of Carper has been expanded by other scholars such as White, who introduced a fifth way of knowing, that is socio-political knowing. White points out that although other patterns of knowing address the who, how, and what of nursing, the wherein was never identified. This way of knowing relates to the cultural identity that exists within the nurse-patient relationship. Therefore, social context could stimulate the manner of nursing practice and identify ways of initiating change. The lack of assertiveness and avoidance behaviour may have something to do with early socialisation experiences and the incongruity between personal values and some of the roles ascribed to the professional nurse, particularly in Saudi Arabia. This is according to Suleiman 2010. The responses to the emotional intelligence questions could be influenced by the orientation towards family roles, and the belief in the subordinate role of women to men may have been reinforced by cultural and religious values, specifically among Saudi nurses. Knowledge level results. The graph illustrates the knowledge level of the participants pre and post intervention. The majority of participants had moderate knowledge in both pre, 73.7%, and post-test, 63.2%. Only a few participants had good knowledge in pre, 10.5%, and post-test, 15.8%. The remaining participant indicated less knowledge in pre, 15.8%, and post-test, 21%. Learning style inventory results. The graph on the left shows the preferred learning mode obtained from the results of the learning style inventory. The results indicate that more than half of the participants, 52.63%, had highest concrete experience scores, followed by reflective observation, 21.5%. Active conceptualization, 15.79%, and active experimentation, 10.53%. The graph on the right illustrates the learning style preference of the participants extracted from the same learning style inventory results. The majority of the participants were convergers, 36.84%, followed by divergers, 31.57%. Assimilators were 15.79%, and accommodators 10.53%. Only one participant, 5.3%, is between diverger and assimilator, because his or her coordinates 2.0 were on the x-axis of the graph. Findings. To determine whether a difference existed in the knowledge of nurses before and after the intervention, a t-test for paired data was employed. T-test was used because data was normally distributed and the variance was equal. The results showed that the difference between pre and post-test had a mean of minus 0.053, and the 95% confidence interval was lying between minus 0.64 and 0.53. The results showed that the difference between pre and post-test had a mean, the mean difference is small and statistically insignificant, which is reflected by the p-value, which is 0.853, indicating no significant difference was observed in the knowledge of nurses before and after the intervention. The result from the nephrology knowledge questionnaire indicated that the education intervention did not improve the nurse's knowledge. The findings are context specific and therefore not generalizable from one setting to another. However, it is encouraged to compare settings against each other, as commonalities may exist which could be applied to all organizations. Further studies are required to evaluate the effectiveness of the current program. The negative result in this study may be attributed to several factors, such as the small sample, 19 nurses, and selection bias in the study, as nurses already had moderate knowledge pre-intervention. It is also important to note that the majority of participants, 63.2%, had a certificate in nephrology nursing. The high concrete experience scores of the participants, 52.63%, indicated that they were more concrete than abstract learners in the abstract concrete continuum, whereas the high reflective observation scores showed them to be more reflective in the active reflective continuum. This finding supported Kolb 1984 and Lassinger 1990, who asserted that concrete learners tend to choose people-oriented professions such as nursing. The results of this study also revealed that the predominant learning styles of the participants were converger and diverger, followed by assimilators and accommodators. Kolb and Kolb 2005A indicated that the divergers have concrete experience and reflective observation as dominant learning abilities. The results of this study were inconsistent with that of Kolb 1984 and Kolb 2005A, but the difference in findings could be attributed to the unique way each learner may apply learning style preferences and his or her capacity to adjust learning styles to a particular learning environment. So recommendations. Further studies are required to evaluate the effectiveness of the current programme. Further studies that link the acquisition of nephrology nurses' knowledge to pre-end-stage kidney disease patient outcomes are recommended. For example, incorporating the aesthetic know-how component of teaching as a conceptual element into Kolb's learning cycle could help nephrology nurses understand the art of renal nursing. Nutrition is an important topic that was identified from the questionnaire that could be used as an important concept utilising the framework of Kolb's experiential learning cycle. Topics related to health promotion are important at this stage of end-stage kidney disease, but were not part of this project. Self-care strategies to prevent infection are some other approaches that may improve knowledge and be also used as concepts. Incorporating the socio-political knowing of wherein may also help broaden the base of experiential learning theory and close the gap currently found between social and personal learning. This study did not compare the effectiveness of didactic teaching and experiential learning in the pre-dialysis clinic. A pre-post-test study designed to assess the comparative effectiveness of didactic teaching and experiential learning is recommended to hypothesize if experiential learning would yield higher knowledge levels in nephrology nurses than didactic teaching. Further studies are required to explore other determinants of learning, such as the learner's readiness to learn, as well as the relationship between learning style preference and demographic variables, such as age, education level, and years of experience, culture, and learning environment. The active involvement of non-expert nephrology nurses in the experiential learning cycle will provide the opportunity to improve their orientation process by learning the skills to practice without causing harm to patients. These nurses will be responsible for future adaptation of the training program design as concepts from the theory that are potentially useful to guide curricular instruction need constant evaluation. So in conclusion, the aim of this project was to review Kolb's experiential learning theory to inform the educational role of nephrology nurses in a pre-dialysis clinic in Saudi Arabia. The study employed an action research methodology approach to reveal important information regarding the learning needs and learning styles of nephrology nurses. The analysis of the nephrology nurse's knowledge through Carper's patterns of knowing is a method of inquiry that has highlighted information needed to enhance practice. The incorporation of Carper's 4 different patterns of knowledge will help nephrology nurses to address the goals of pre-end-stage kidney disease patients and could be incorporated into Kolb's learning cycle as part of the pre-dialysis curriculum. Understanding and knowing the learning style situate the learner within the learning cycle continuum. Learning style appears to be a crucial component in ways of knowing. However, it is not a fixed personality characteristic. Instead, it should be viewed as patterns of behaviour based on personal experience, education, values and roles. Provisional feedback from project participants revealed that nephrology nurses are ready to utilise this new way of learning now that Kolb's theory has been deconstructed. Incorporating Kolb's learning theory into the newly proposed pre-dialysis curriculum will promote critical thinking and help non-expert and expert nephrology nurses to reflect on experiences and identify strengths that need improvement. References. Thank you.